So we're going to switch gears from valves and go into something we do with valves, and that's fix atrial fibrillation. And there's actually somehow, I guess there was a typo on the schedule there. So this talk is supposed to start at 10 and end at 10:30, but we won't go 30 minutes. So I think you'll get out in time to have a quick break and then go straight into the arrhythmia talks, the medical arrhythmia talks. So if we'll hopefully get you there, and so I'm going to skip over a lot of the medical side of atrial fibrillation treatment. So Jim Cox was spent his entire career developing surgical treatment for atrial fibrillation, and he really invented what's called the Cox-Maze operation through various iterations. Started with the corridor operation, Cox-Maze 1, 2, and 3. Now we're doing the Cox-Maze 4 operation, which is very similar to the cut and sew Cox-Maze 3 with some changes. So these were the most of the lesions involved in the Cox-Maze 3 operation, which included cutting off both atrial appendages, right and left, and included cutting and sewing, so you knew you were transmural, you knew that your lesions were continuous, which is the most important thing to the efficacy of AFib surgery, is making sure that your lesions are continuous. They had a number of areas that were difficult, and one was back here in the mitral isthmus area, where you're cutting up towards the mitral annulus and going across the area with the coronary sinus and the left circumflex artery, and the other was up near the tricuspid valve going across the AV groove. Working in the back of the left atrium and cutting up the left atrium and sewing it back together can be technically difficult and take some time. And so the pump times were long in some people's hands, not so long in others. And the biggest problem technically the biggest problem with patients clinically coming out was the absence of both left atrial appendages, because in hearing conversations from the cardiologists who were rounding on these patients after these operations with the cut and sew maze, they shudder every time we say the word maze, because they remember how horribly volume overloaded these patients were because you took out their source of ANP. So you get rid of a lot of their endogenous atrionatriuretic peptide, and it's very difficult to diurese these patients. So the cut and sew maze has been the gold standard by which all other ablation procedures are measured, including the cath lab procedures and anything we do surgically. It's very effective. It was 92 to 97% freedom from AFib, even out to 5 years. There were almost no strokes in multiple series from multiple centers, which is amazing, because AFib alone gives you a much higher increased risk of stroke. There was a low mortality rate. The operation appeared to be durable, but again, it was technically difficult. It was never universally adopted, and it didn't achieve widespread use. Just like Dr. Reardon showed Brunwald and Ross's picture of the drop-off in AFib, drop-off in aortic stenosis, we base a lot of what we do in AFib surgery and in catheter ablations based on Hasseger's study from 1998, where he showed that he could find the foci that triggered AFib in 45 patients in the cath lab. These were all patients with paroxysmal AFib, and he was able to locate the trigger site of AFib in 45 patients. So a lot of this data that everybody talks about, the AFib foci clustering around the pulmonary veins, that's true in a lot of patients, but this was 45 patients, isolated AFib and paroxysmal AFib. And so we know that there's a substrate and triggers that are needed to sustain AFib. The pulmonary veins don't tell the whole story, but all ablation techniques should go through the pulmonary veins. So there are various transcatheter techniques. Isolating the root of the pulmonary veins is dangerous, because you can get pulmonary vein stenosis if you get a circumferential lesion on the individual pulmonary veins. you have to worry about the transseptal approach, and you have to worry about radiofrequency with the esophagus right behind the left atrium. So the complications of catheter ablation for AFib include cardiac tamponade in 6%. Pulmonary vein stenosis depends on how hard you look for it. If you do CTs on everybody, one study showed up to 38% of some pulmonary vein stenosis with catheter ablations. Esophageal injury, thankfully, is a low risk of esophageal injury because it's a devastating complication, and any of you have ever been in on those operations don't ever want to be in on another one. Phrenic nerve injury occurs, thromboembolism, arrhythmias, vascular injuries, and several different complications. So this is a thrombus I took out of a patient, and it was stuck to his percutaneous AFib ablation line. So you can see in an attempt to treat the stroke, they created an area of char that collected thrombus. Now the surgical maze procedure, this was studied back in, reported in 2002, where they randomized patients to either MVR plus maze, or mitral valve repair plus maze. And in this study, they showed there wasn't a significant difference in survival, but the freedom from AFib rate, if they just fixed the mitral valve, was only 6%. If they added a maze procedure, it was 80%. And the freedom from stroke was 79% in the MVR alone group, where it was 97% in both the MVR plus maze and the MV repair plus maze. And so we do feel that a maze procedure will protect from stroke, and it gives you a much better freedom from AFib than just mitral valve surgery alone. Other randomized trials with alternate energy sources now have shown that also in the control group, the mitral valve repair alone rates are anywhere from 10 to 30%, whereas the maze procedure, in addition to mitral valve surgery, is usually around 80%. So there have been multiple energy sources on the market. Some have survived, some have not. Epicor ultrasound device did not survive. Microwave was shown to not create very good transmural lesions. Lasers didn't create good transmural or continuous lesions. And some of the bipolar clamps for radiofrequency delivery, some of the unipolar radiofrequency delivery, and the cryo catheters have survived the scrutiny of the initial wave of AFib surgery. So now typically the only real alternate energy sources are either radiofrequency or cryo, and there are various ways of utilizing these energy sources to create lesions. The goal is to create transmural lesions that are continuous to recreate the idea of the maze procedure. We've talked a lot about guidelines, and I just want to, as we're talking about expert consensus statements and guidelines, it's very important for you guys to know the background of how these guidelines came about. So these are 120, 130-page documents, but it is very important if you're going to do AFib surgery, get a copy of the most recent guidelines, read through it, and kind of figure out where they came up with these ideas, because a lot of the studies that they're based on may not be the greatest studies on earth. And remember that guidelines are guidelines. They're not absolutes, and they're not everything for every statement. But it is very important that you get to know the literature, and the guidelines are a good place to start to kind of get an idea of what's out there and what the experts have based their decisions on. So the valve surgery guidelines and the coronary surgery guidelines and the AFib surgery guidelines, I think, are a critical starting point for you, and always have those in your reading selection. So the guidelines, indications for surgical ablation for AFib, symptomatic, and I will repeat, symptomatic AFib patients undergoing other cardiac surgical procedures. Selected asymptomatic AFib patients undergoing cardiac surgery if ablation can be performed with minimal added risk. So those are very important statements that they came up with. And then standalone AFib procedures for surgery can be considered in symptomatic AFib patients who prefer a surgical approach or have failed one or more attempts at catheter ablation, or patients who are not candidates for catheter ablation. And that's basically your guidelines for indications for surgical AFib. So you have to remember that the surgical addition of an AFib operation is if you think you can do it with minimal or low added risk. So typically, surgical ablation should be considered in patients with persistent and permanent Afib because the catheter ablation results are not very good with persistent and permanent Afib. It should be considered in patients who have had long duration of Afib. If you've only had Afib for during this hospitalization, when you found your MR and you go in and you fix the MR, you're probably not going to need a surgical maze. Patients who have a large left atrium or left atrial thrombus are not really good candidates for catheter ablation Afib, and so if they're terribly symptomatic and they need Afib, this is a good Afib standalone surgery indication. Patients who have atypical left atrial flutter, so the cardiologists often will not be able to completely ablate the mitral isthmus area, and so they often get atypical left atrial flutter, which is harder to treat than Afib medically. And so a lot of, probably 70% of the standalone mazes that I've done have been referred to me because of atypical left atrial flutter, usually after 3 or 4 attempted percutaneous ablations. Failure of catheter ablations, or if they have an indicated cardiac surgery. So when we're doing open heart surgery, the likelihood of patients having Afib when they come to the operating room for mitral valve surgery, it's anywhere from 33 to 50%. CABG has been shown to be to patients going to the operating room for coronary bypass surgery. Up about 14% of them will have Afib when they come to the operating room. AVR anywhere from 11 to 21%, and then you can see down as you get into more risky CABG, AVR, MVR, high likelihood of Afib. Obviously, all standalone mazes should be an Afib. If you look at all open heart surgery, going to the operating room for open heart surgery, about 10% of those patients have Afib when they get to the operating room. So my indication to add an Afib ablation is if they have an indicated operation. This is for concomitant surgery. If they have the presence of Afib, if they have minimal added risk in the presence of an atrium. The alternate energy sources efficacy is very difficult to ascertain through the literature. Everybody has there's a lot of Afib surgeons that use the literature as marketing tool. So there's a very widespread heterogeneity in the literature. Various lesion sets are used even within studies, within single center, single operator studies, various lesion sets are used. They use epicardial, endocardial lesions, or both. Several studies have combined intermittent and continuous Afib. Duration of Afib is very often not stated in the studies. And antiarrhythmia therapy is very variable. There are concomitant procedures mixed with standalone Afib procedures, and various etiologies of Afib are used. Also, the follow-up evaluation of Afib is difficult. Several studies just do spot check EKGs when the patient comes back to clinic, and if a patient started out with paroxysmal Afib, there's a high likelihood that they'll be in sinus rhythm when they come back to your clinic, even if they're not fully treated. So we have to, the guidelines of how to follow up these patients have been very good at trying to get a lot of this heterogeneity out of the studies being done. And there are several ongoing studies that are getting better. So we've actually adapted the lesion to fit the energy source instead of adapting the energy source to fit the lesion set. You can do all of the left-sided lesions of the Cox maze operation using endocardial cryoablation. You can use epicardial lesions. But in this study, they actually showed the lesion going towards the coronary sinus but not across it, which is very dangerous for left atrial flutter. With the bipolar clamps, if you're not going to open the left atrium at all, you can't really do much other than just pulmonary vein isolation. In order to get the complete lesion set, you have to open the left atrium. So these are just various lesion sets that mimic the Cox Maze 3 operation. You can do all the lesions with endocardial radiofrequency and cryo. the epicardial radiofrequency with a unipolar approach may not be fully transmural because of the epicardial fat. And then you can do pulmonary vein isolation alone with the clamps. But if you're going to do the connecting lesions, you really have to open the left atrium. And this is a way of getting around the pulmonary veins. This was an old clamp that's off the market now, but it's very similar to the AtriCure clamp that's currently on the market. And you can see just passing it with a red rubber tube around the pulmonary veins is very simple when you've passed the red rubber tube around already. That way you don't hit anything with the jaws of the clamp. Now AtriCure has a new device that you guys got to see in the lab that passes the red rubber tube much more easily in a dissecting tool. Here you can see there's a lot of fat on the epicardial surface, and again we're opening up Sondergaard's groove here, and we're separating that a little bit. You can see just opening up that fat takes a lot of the insulating fat away from the epicardial surface. Now the other thing you can do, you can actually open the left atrium and use the radiofrequency clamps to create the lesions, and we showed you in the lab how you can do all the lesions of the Cox-Maze 4, but you do have to open the heart and be on pump. So the surgical outcomes, if you use bipolar radiofrequency for the Cox-Maze 4 operation, if you do the full lesion set biatrial, the freedom from AFib is 90%. If you just do the left atrial lesions, it's pretty close at 86%, but if you just do pulmonary vein isolation alone, usually the results are about 50 or 60%. So always remember that a pulmonary vein isolation alone is not a maze procedure, and you have to take that into account when you're talking about minimally invasive approaches and what lesion sets you can actually do. Now you can do the entire lesion set from a small right thoracotomy using endocardial cryomaze that requires going on pump and opening the heart, but you can also sew up the left atrial appendage through that approach. And this is just showing the cryomaze. We talked about this in the lab, so I'm going to pass by that. Remember that the challenge of conductive sources, if you're doing epicardial applications, the blood within the left atrium will cool the surface of the endocardium if you're using radiofrequency, or it'll warm the surface of the endocardium if you're using cryo, and so you may not get a transmural lesion. And remember that fat is insulating, so you can insulate whichever thermal source you use. Endocardial application, be careful of endothelial damage, especially the charring from radiofrequency, which has a thromboembolic risk. Endocardial application should be done off pump, and you have to be careful of collateral damage. Always pull the TE echo probe back whenever you're doing any kind of maze procedure, even if it's just bipolar and they tell you there's no collateral damage. Always pull the TE echo back. So a hybrid approach works well. You can do the inside out, outside in, where you can do an endocardial cryomaze, and then they can do radiofrequency of the right atrium. So there are several options. Just remember the catheter ablation looks like this, whereas the surgical ablation looks like this. You have to cross the lesions, and you have to have continuous lesions. We know that if we have gaps, it's not going to work as well. Always close the left atrial appendage when you do a maze. That's a part of the procedure, whether you use a clip or sew it up. And when you sew up the left atrial appendage, don't do a purse string or a figure of 8. Those have been proved to not work well and actually increase the risk of stroke. So we have insufficient data right now to declare surgical or catheter ablation as first-line therapy. Medical management is still first-line therapy for AFib. The guidelines for reporting data have to be followed to know what we're really doing as far as follow-up data goes. And the surgical risks have been, the surgical results have been promising despite high-risk patient populations in surgery as opposed to catheter approaches. Hybrid approaches have to be studied carefully, but the early results are promising. And the maze procedure should be considered for patients with AFib requiring cardiac surgery and for selected standalone AFib patients. The efficacy requires transmurality and continuity of the lesion, so think about that when you're choosing which lesion sets and which energy sources. and the outcomes improve with lesion sets that more closely resemble the Cox-Maze 3 operation. And the bottom line is never compromise the results for the incision.